Thank you very much. Now, that concludes, we've concluded topical questions. We're going to move on now to our next item, which is a statement by Jean Freeman on supporting care homes during COVID-19. Cabinet Secretary will take questions after a statement. I would encourage all members who wish to ask a question to press the request to speak buttons. And I call on the Cabinet Secretary, Jean Freeman.
Thank you, Presiding Officer. Today I want to set out the steps we've taken, including the additional action set out over the weekend and yesterday to support residents and staff in care homes across Scotland as they deal with the impact and the challenges of COVID-19. While the majority of people who contract the virus experience mild to moderate symptoms, for our most vulnerable citizens, COVID-19 is a vicious virus. And amongst those most vulnerable to its impact are those who are older, who are frail and who have existing health conditions. Many live in care homes, but these are not just institutions, of course. This is their home. And not all care homes are the same. The care home sector in Scotland is provided primarily by private sector businesses, with a smaller proportion of owners from the independent and third sectors and from public authorities. There can be no doubt, however, that the staff who work in care homes, all care homes, and those who work in community social care, like our staff in the NHS, are committed to doing their very best every day and are sorely tested in the face of the risks and the challenges they are dealing with in caring for their residents in the face of this pandemic. In early March, we issued clinical and practice guidance for care homes. This set out what we believe to be the risks and the resultant clinical and practical steps to be taken, the ending of communal activities, communal dining and unrestricted visiting. That guidance was then updated on the 26th of March and again on the 15th of May. Each iteration is a reflection of our growing understanding of the virus and of the situation on the ground in some of our care homes. As global supply chains for PPE became increasingly challenged and the normal private supply routes to the care home sector were disrupted, the NHS National Services Scotland Social Triage Helpline was launched on the 19th of March, so that at a national level we could step in and respond to urgent requests for PPE by social care providers, including care homes. We increased our own NSS order volumes to make sure we could cope with this additional demand, not only from the social care sector, but also from primary care and pharmacy, as well as additional demand from acute care. To make sure we could get the right PPE to the right people, we created direct distribution routes, including local PPE hubs for social care providers, covering care homes, and direct distribution where that was needed. This was and continues to be a remarkable logistical achievement by those involved, and I want to record my thanks to NSS and to local health and social care partnerships for their considerable and continuing work in this area. For care homes, as for the NHS, an area of concern was sustainability of the workforce. Social care workers, alongside NHS staff, have been the first priority group for testing from the outset. In many cases, staff were absent because a member of their household had COVID-19 symptoms. So the testing was designed to ensure that a positive confirmation or not of the presence of the virus would either confirm the need for absence or allow staff to return to work. This must also mean that there is availability of a backup workforce to ensure rotas are stable. Following the call of social care and a call to social care and NHS staff who had left the profession to volunteer to return, the Scottish Social Services Council National Accelerated Recruitment Portal went live on the 29th of March, so that people with relevant skills and experience could come forward and be ready for deployment. By yesterday, the 18th of May, 895 individuals have been cleared to work in a variety of social care settings, including in care homes. 254 of those have been matched with employers so far. So there are still several hundred additional employees checked, cleared and skilled, ready to begin work. And I am today, as I have been, urging providers to make full use of this significant additional resource. We also recognise that it was inevitable that the pandemic would impose additional costs in the social care sector, as it has done in health. So working with COSLA, the trade unions, Scottish Care and double CPS, we were able to announce a national uplift to the total hourly contract rate of 3.3% for adult social care providers starting from the 1st of April. We also reached agreement with COSLA to meet other additional costs incurred, including additional payment to third sector and independent care providers working on local government contracts to cover sick pay in line with terms and conditions for all staff who are off work because they're ill or because they are self-isolating. And on the 12th of May, I announced an initial £50 million to support social care provision commissioned by health and social care partnerships in care homes and care at home services to provide resilience within the sector and to deal with increased need as a result of COVID-19. As I've said, social care workers have been in the priority 1 group of key workers from the outset, and to date around 30% of all key workers tested have been from social care. But I'm also aware that there are social care workers who, because of their employment contract, are anxious about being tested because if they test positive and go off work as they should, their weekly income will be reduced to the level of SSP. For those workers, this is an intolerable position to be in, a terrible choice between your commitment to the care of residents, your own health and that of your family, and the risk of a significant and unmanageable reduction in your income. This arises solely from the contract the employer has put in place, so it is not the case for all social care workers. But for those affected, it is an impossible choice we need to resolve. Yesterday, I spoke to Donald McCaskill from Scottish Care, and I know that he and COSLA are meeting today to discuss how this can be resolved. I've asked for an update following that meeting, but I have been clear to him and to the unions who have raised this with me that where I can, I will help to resolve this matter. On the 15th of April, the First Minister announced that all symptomatic patients in a care home would be clinically assessed and offered testing for COVID-19. 2 days later, the medical officer wrote to all health boards to ask them to make available testing to all residents and staff in a care home which has an active case of the virus. We have taken steps to ensure that admissions to care homes are tested in advance of admission, and in the case of community admissions and those from hospital where the patient was not in hospital for COVID-19, residents are also isolated for a period of 14 days on admission. And finally, yesterday I announced that all care home staff will be offered testing, regardless of whether the care home in which they work has a COVID-19 case or not. This will be an iterative process with testing undertaken every 7 days. We will begin this work from next week, and we're working now with our NHS testing capacity, senior NHS staff and Scottish Care to plan the implementation of this, including the prioritisation of those care homes for testing. Every effort will be made to ensure that testing can be undertaken as close to a care home as possible. Just as this virus is new to scientists and clinicians around the world, it is also new to the social care sector. They, like us, are having to learn, adapt and improve their response as our understanding grows. That includes increasing the level of clinical oversight and practice expertise that we provide to ensure the welfare of residents and staff during this time. We already have a very effective system of inspection for social care in Scotland, and the Care Inspectorate, now with their partners in Healthcare Improvement Scotland, are actively engaged in direct inspection of individual care homes, providing support and guidance, but also escalation where that is required. From the 20th of April, NHS Directors of Public Health have taken on enhanced and urgent clinical leadership for care homes in their board area, working closely with the Care Inspectorate, with local authorities, GPs, district nurses, and supported by the Care Homes Clinical and Professional Advisory Group, overseen by the Chief Medical Officer and our Chief Nursing Officer, and by the Care Homes Rapid Action Group. On the 17th of this month, I set out a further enhancement of these arrangements, with the requirement that each board medical director and nurse director and each local authority chief social work officer and the chief officer of each health and social care partnership would work to provide direct and frequent engagement with each care home in their area to ensure effective infection prevention and control practice, testing as I have set out, adequacy of PPE and its appropriate use, and the robustness of staff rotas, providing direct NHS staff support where that is required. These arrangements are not about medicalising the provision of care in care homes, which, as I've said, are people's homes. They are, though, a necessary response to a national emergency that has to be centred on public health and clinical need. And of course, members will be aware of the important Stage 2 amendments to the coronavirus emergency legislation being considered by this Parliament today and tomorrow. I will not encroach into that debate, but I will say firmly that I consider these amendments necessary to provide the safety needed of immediate action in particular circumstances to secure the safety, well-being and continuity of care home residents. Presiding Officer, I have set out as best I can all the key steps we have taken to ensure the safety, protection and well-being of residents and staff in our care home sector. This is not the end of our work by any means. I am certain there will be more for us to do and more improvements to make. And where that is the case, members have my assurance that that is what we will do. Thank you.
Thank you, Cabinet Secretary. The Cabinet Secretary will now take questions. Miles Briggs, be followed by Rhoda Grant.
Thank you, Presiding Officer. From the outset of the outbreak, ministers were pressing health boards to discharge vulnerable patients into care homes. So can the Cabinet Secretary say today how many patients were transferred from NHS facilities to care homes, either untested for COVID-19, with results unknown at the time of transfer, or following a positive test without the results clear at the start and from the start of this outbreak? And given the most recent clinical guidance which ministers have issued only suggests that people should ideally have 2 negative tests before discharge from hospital, does the Cabinet Secretary now not accept that we've seen a dysfunctional approach to testing in care homes across Scotland? And if not, where does the Cabinet Secretary actually believe that the management of the spread of coronavirus across Scotland's care homes has gone so wrong?
Cabinet Secretary.
So in total, as of March, at the end of March this year, no, that's not quite right. In total, as of last week, the percentage of delayed discharges going to care homes was 38%. 62% of people who were discharged from hospital went to their own homes with the appropriate social care package. So that's the number of delayed discharges, and I refute the idea that we were forcing people out of hospital in order to clear the way for COVID-19. Actually, those 3,000 bed spaces that we cleared came primarily from the key areas of healthcare that we took the very difficult decisions to stop, not least elective procedures. All of the members in this chamber have, from time to time, made the perfectly legitimate point that our delayed discharge figures need to be reduced. What happened in response to the COVID pandemic, as in many other areas of healthcare, is that we had managed to achieve some changes and improvements we had spent many years trying to achieve. The use of digital being one of those, the incredible expansion of Near Me being another. And so the focus of our health and social care partnerships was to reduce the number of delayed discharges in order to ensure that those individuals had the best possible care and not in hospital when they no longer needed to have the clinical care of hospitals. And I don't accept that the response has been dysfunctional. Mr. Briggs quotes selectively from the guidance. We all know that the right clinical decisions for elderly and frail individuals is to not be in hospital when their clinical care is no longer required to be in hospital, that is not the best place for them. And some clinicians will go as far as to say, including geriatricians, that is a positively bad place for those individuals to stay. So moving people to their home or into a care home is the right thing to do when clinical care is no longer required in a hospital. And what we have said is, where the test can be done 48 hours if there are a COVID patient in hospital before discharge, 24 hours if they're not, 14 days isolation. Testing is not the single silver bullet to prevent the transmission of this virus. Quality infection prevention and control, which should exist in our care homes in any circumstance, is the primary way by which you prevent the transmission of this virus.
Rhoda Grant, to be followed by Alison Johnson.
Thank you, Presiding Officer. The announcement of regular testing and care home staff is very much welcomed, albeit it should be on a much greater scale. I've continually requested an emergency protocol for care homes, putting down a written question on 4th of April and subsequently writing to the Cabinet Secretary, hoping for a faster response. All I've received is an acknowledgement and a holding response. The lack of a clear single protocol has been disastrous. The Home Farm care home in Skye showed that it had an overwhelming level of infection when testing did eventually occur. Since the very beginning of this crisis, Scottish Labour have repeatedly highlighted that testing in care homes is the advice of experts both in Scotland and the World Health Organisation and other international agencies. Can I ask the Cabinet Secretary to outline exactly what scientific advice has changed and that the Government now accept the need for regular staff testing in care homes? And while the rollout starts next week, when does she expect this level of testing to actually be available in every one of Scotland's care homes?
Cabinet Secretary.
So I'm grateful to Ms Grant for her question, and I should start with an apology to her for the delay in responding to her, and to say, in advance of you receiving a proper response, I am very happy to meet you to discuss what you think should be in an emergency protocol and to consider whether that is something that we can usefully do to add to what's already been done. And my office will be in touch to ensure that we have that meeting as soon as possible. The recent change, which is to offer testing to staff, regardless of whether there is a COVID case in the care home that they work, and what has changed to allow that to happen. As I'm sure the member and others will recall, at the outset of our understanding, indeed our scientists and clinical advisors' understanding of this virus, the view was that if you were not symptomatic, you were unlikely to be infectious, and that the test was not reliable. That view has changed over the peace, in that there is increasing evidence and debate in the scientific community about the degree to which asymptomatic and pre-symptomatic individuals may be infectious. And whilst the test is not as reliable in asymptomatic individuals as it is in symptomatic individuals, nonetheless, the advice has changed to say that given that there is a growing debate about the level of infectiousness of individuals who are asymptomatic or pre-symptomatic, the use of the test in those circumstances, in something like a contained area, like a care home, for preventative purposes, bearing in mind that you have to then keep repeating it every 7 days to be sure, is on balance the right thing to do. And that is why we have changed that position.
Alison Johnson, to be followed by Willie Rennie.
Thank you. I welcome the introduction of regular testing in care homes. Greens have long called for this, but it must be expanded to the NHS staff too. Now, Public Health England research, which looked at care homes in London, shows that in some cases, workers who transmitted COVID-19 had been drafted into cover for others who were self-isolating. And HC1, who operated Home Farm Care Home on Skye, has admitted that it brought in temporary staff from outside. PPE and regular testing significantly reduce the risk of transmission. They're hugely important, but of course they don't eliminate it entirely. So I'd like to understand what action the Scottish Government is taking to, with the sector to minimise the movement of care home staff between care homes. Thank you.
Cabinet Secretary.
So, the members in questions are particularly important, particularly around, well, on both areas, but in terms of the situation in hospitals. Our Chief Nursing Officer is currently working through with her clinical colleagues some additional advice that she intends to give about what more we can do in the hospital setting in order to minimise the transmission of the virus there. You already know, of course, that we have red and green zones, but there are other areas, other steps that it might be wise for us to take in order to ensure that we minimise as far as possible transmission in a hospital setting between staff in one zone to another, but also otherwise that may be useful to take. And once we have that advice, I will update members on that and update them too on any subsequent decisions that we take. Members also write about the importance of not transferring staff from one home to another, and certainly not without testing to ensure that the new staff that you introduce are clear of the virus at that point, bearing in mind that the test tells you that you are positive or not on the day that you are tested. One of the areas that is really important, that's why we have now involved not only our directors of public health, but our nurse directors and our medical directors, is to make sure that we can offer NHS staff to those homes rather than have them move their own staff from one care home to another, not least because in doing so, they may make the home that they have taken staff from vulnerable in terms of its staff rotas, and therefore vulnerable in terms of its capacity to do effective infection prevention and control. And the Chief Nursing Officer has been very clear that where NHS staff and indeed care home staff are going new into a home, they should be tested first before they go. Already, a number of our health boards have provided NHS staff to care homes in order to backfill the rota and in some instances to increase the level of staffing in a particular care home where there is an active case.
Willie Rennie to be followed by George Adam. Willie Rennie.
New residents from the community could still be admitted into care homes without having a negative test first and the results back first. Can the Minister fix this? On testing of all staff, why is it necessary to be iterative? Why not just do everyone immediately? The situation at Home Care Farm on Portree is a terrible one, and the application has been made to cancel the registration. Is the Cabinet Secretary planning to cancel the registration of other homes as well?
Cabinet Secretary.
So my apologies, Mr Rennie, I think I'm about to miss the very first thing that you asked me, but I'll start with the last thing. It is not for me to cancel the registration of any care home. The Care Inspectorate is a very serious matter indeed. The Care Inspectorate has applied to the court for the court to consider the deregistration of HC1 as the owners and providers of Home Farm Care Home in Skye. And because it is now in that court area, it is not appropriate for me to say anything more about that, except to repeat, it is not for ministers to cancel registrations. It is the Care Inspectorate approves registrations. If it wants to cancel them, it needs to go through that court process. The reason why it is iterative, that should not be taken to mean it doesn't happen now. What it means is that if I was to test negative today, then that tells us all that I do not have the virus today. But if I want to be sure that my continued work in a care home means that I am not risking bringing the virus into that care home, you need to test me every 7 days to make sure that every 7 days I continue to be negative for coronavirus. And the 7-day period is the clinical advice about how often the testing should happen. So that's what I meant by that, that if we go into care home X and that doesn't have a case, we test all those staff, they are negative, we need to go back in 7 days' time, otherwise it's just a one-off. And so in that way, my understanding is our position differs from the approach that is being taken by Public Health and NHS in England. My apologies if I have missed the first part of your question, but I'm happy if you want to give me it later, I will make sure you have the answer. Or you want to ask me again?
Okay, we'll do it later, I think. Mr Adam to be followed by Brian Whittle. George Adam.
Thank you, Presiding Officer. Can I ask the Cabinet Secretary to expand on some of what she said earlier on, that if the NHS and local authorities have staff available to support care homes who have insufficient staffing due to COVID-19, and if any have been deployed to care homes in recent weeks?
Cabinet Secretary.
So, the member will recall that we made that call to NHS and social care staff who had recently left the profession to volunteer to return. They will be employed if they are deployed back into the health service or into social care. It would be a proper contract of employment. We had 1,916 expressions of interest for social care roles, and the numbers that have gone through all the pre-employment and other checks that are required, I gave in my statement. The number who have been deployed into care homes, I also gave in my statement. The decision about whether or not those individuals are deployed into care homes rests with the care home provider. I cannot tap them on the shoulder and send them into a particular care home. So that's why in my statement I urged care home providers, if your rotas are fragile or you need more staff because you need to up the level of staffing to ratio to residents because you have an active case, then there are people here ready and willing and able and expert to be deployed. What I can do, though, is I can ask NHS staff to volunteer to be deployed. And that is what we have done in order to cover if providers are not coming forward, making those requests for those returning individuals with social care experience.
Brian Whittle, to be followed by Jackie Bailey.
Thank you, Presiding Officer. Cabinet Secretary, the Care Inspectorate instigated an unannounced inspection of the Home Farm nursing home on Skye, which has resulted, as you said, in the Care Inspectorate applying to take over the running of that nursing home by the NHS. Given there are unfortunately so many tragedies throughout Scotland that have not led to similar action, can I ask the Cabinet Secretary what the protocols are for such interventions by the Care Inspectorate and the Scottish Government in care homes?
Cabinet Secretary.
So the Care Inspectorate is largely, well, A, it is independent, but it is also largely responsible for determining which care homes it wishes to inspect, either as an announced or, importantly, as an unannounced inspection. It has taken the view that in terms of inspecting care homes, it should do what I would call a live inspection, so it physically goes to the care home with the appropriate PPE and so on, enters the care home and undertakes the inspection. It does that largely by looking at two things. One, those care homes that it has already assessed in its RAG status as red or amber, and two, those care homes where there is an active case. And whether or not the inspection is announced or unannounced is for the Care Inspectorate themselves to decide. So they have a means by which they do this, and they are largely independent in acting in that way. They are, however, actively engaged with us in all this care home work that I have described in my statement, recognising their particular role. And in this instance, for care home inspections, they have now made a partnership with Healthcare Inspection Scotland, who have very particular expertise in infection prevention and control. And in many cases, those inspections will be joint inspections by the Care Inspectorate and his.
Thank you very much. Jackie Bailey, to be followed by Sandra White.
Can I welcome the Cabinet Secretary's announcement about testing, but it is months late. We've witnessed a lack of testing for staff, really nothing in place until the third week in April. We've witnessed the reluctance of care homes to send their staff for testing because of concerns about staff absence. We've witnessed the lack of PPE and PPE being locked in cupboards whilst coronavirus raged through care homes. Let me ask the Cabinet Secretary, why was none of this done sooner? Why have we had a patchwork approach to care homes with constantly changing guidance? And let me also ask her, where have the Care Inspectorate been? Because the truth is that the Care Inspectorate have been posted missing. Instead of stepping up to the plate, they've actually stepped back and taken a light touch approach. At a time when people are dying in their hundreds in care homes, did the Scottish Government agree to the Care Inspectorate stepping back?
Cabinet Secretary.
So part of the difficulty, and the reason I mentioned this so early in my statement, is that the care home sector is primarily delivered by private business. Something like 70% of care homes are private businesses, either individual small businesses or part of a much larger chain. There are then, of course, independent, third sector and public authority care homes, but they are the minority. So in that circumstance, there is a degree to which my capacity, or any health secretary's capacity, to direct and instruct is limited in a way that it is not in the health service, because as a member will recall, some time ago in early March, I think, I put the National Health Service in Scotland on an emergency footing in order to ensure that the things that I thought it needed to do, I could be sure that regardless of individual board opinion, it was doing in a consistent way across the country. The care sector, the care home sector, is not like that. And so there is, of necessity, a different approach. Now, whether or not that is the right place for us to be, whether or not in the medium to longer term we want to be in a different place is an important debate for a different day. But I have to deal with the reality of the sector that I currently have. So the reluctance of providers to send staff for testing, the PPE in cupboards, I would not dispute any of those. The point of now the significant enhanced clinical guidance, direction and intervention is to overcome those problems as best as I can. The Care Inspectorate took a view, as they were entitled to do, that in the face of the pandemic, the safest in terms of residents of the care homes for them was to undertake inspections and engagement with care homes that did not involve directly appearing in the home. The Care Inspectorate have now changed that position, and I am glad that they have, in order to directly inspect what is happening in those care homes. And that, I think, is a welcome change of decision from them.
Sandra White, to be followed by Graham Simpson.
Thank you very much, Presiding Officer. Cabinet Secretary, yesterday, HC1 care homes reported 1,002 suspected cases and 207 COVID-19 deaths in their care homes. Now, considering the number of homes that they have and beds in HC homes, this to me, and I think others, seems disproportionately high. Can I therefore ask the Cabinet Secretary, will there be a review of the practices of large care home operators? And would she agree with me that the future of elderly care must be a priority for change?
Cabinet Secretary.
So there is a degree of attention being focused in this area by the advisory group to the Chief Medical Officer and then obviously to government that is led by Professor Andrew Morris, that also involves emerging views from the Care Inspectorate about whether or not, and it is not decided yet, it's not a concluded view, so it's important that that is clear, whether or not there is a difficulty in large care homes, that's physically large care homes as opposed to groups of care homes, compared to small care homes, in terms of effective infection prevention and control and the proper support, training and guidance for staff who work in those care homes. So members need to be aware that that debate has begun and that some of it is backed by data and evidence on both sides of that argument. In terms of whether or not there should be a review of large care home operators where they have more than one care home, I think, as I said to Ms Bailey, there is an emerging and genuine need for consideration in this Parliament, by this government, in the medium to longer term, about what our care home sector should be, how it should be funded, who should provide it, and what it is that we require of it in giving the care to our older and more vulnerable citizens, which many of us will be at some point. But that is for the medium to long term. The focus I have to have right now is to deal with the reality that I face, the way that sector is constructed as it stands right now, and navigate my way as best I can through that to ensure that we can maximise the well-being, the care and the support for residents and staff, that it is possible to do so in the current circumstance.
Thank you. Just encourage relatively brief questions and concise answers. There's still a dozen members to go. Graham Simpson to be followed by Neil Findlay. Graham Simpson.
Thank you. This is really brief. I want the Cabinet Secretary to clear something up for me. Can she say if people have been moved from hospitals into care homes without knowing if they had COVID-19 or not, or if the virus was in the home?
Cabinet Secretary.
So I can't give the member a definitive answer to that. What I can do is give him an answer with respect to the date from which we required the 2 negative tests before you left hospital to go to a care home if you were a COVID patient, and the 1 negative test if you weren't, and the requirement on community admissions. I can give him detail of that, and I will do following this debate this afternoon. But prior to that, no, I can't. I am reminded of one other, if I may, with your indulgence, presiding officer, simply make the point about why is it not always the case that those tests are undertaken before the individual moves to the care home. And that, the main reason is where the clinical view is the balance of risk in staying in the hospital as opposed to moving to the care home is greater if they stay in hospital, and the move to the care home can be mitigated while you wait the test results by that requirement for 14 days isolation.
Thank you. Neil Findlay is followed by Maureen Ward.
Why does the Cabinet Secretary applaud care home workers on Thursday evenings, only to instruct your MSPs on the COVID committee today to vote against amendments that would have made them safer and improved their terms and conditions?
Cabinet Secretary.
Because I disagreed with those amendments and don't believe that that is what they would do. I think there are other ways. I'm not going to get into the debate about emergency legislation. That would not be appropriate at this point. But clearly, I think that the amendments that we have put forward are the right ones, and I would hope members will support that. And the amendments that we oppose, I'm sure my colleague Mr Russell is more than capable of setting out our clear reasons for those. And I don't think, as the member appears to be implying, that there is any contradiction between my long-standing, before I was the Health Secretary, support for care home and NHS workers, having been one myself many years ago, and my long-standing support for those workers, and the occasions when I may disagree with Mr Findlay.
Maureen Watt to be followed by Jamie Halker-Johnson. Maureen Watt.
Thank you, Presiding Officer. Cabinet Secretary, can I also welcome the changes to the testing criteria in care homes? But can I ask how this will work in practice? Can I ask whether test kits will be sent out to care homes, especially those in rural areas, so that a nurse there can carry out the testing? Or will it still require somebody from the Health Board or the Social Care Partnership to visit the home to carry out the tests on staff and residents, and thereby perhaps being a delay in the process?
Cabinet Secretary.
So it's an important point, because much of our country is remote and rural and requires quite distance travel in order to reach places. It will be a mix of both, depending on what is going to give us the quickest answer, and that will vary. So on occasion, if the nursing staff, if the clinical staff in a care home have been trained in order to undertake the sampling, then they will be able to do that. In other circumstances, it will be with the deployment of the mobile testing units. We have 12 of those in Scotland. In other circumstances, it will be using local NHS staff. That could be district nurses, for example, or it could be local staff from a nearby acute or primary care setting.
Jamie Halker-Johnson, followed by Ruth Maguire.
Thank you. It has taken nearly 3 weeks from a resident from the Glen Isla care home in Murray being confirmed to have a case of COVID-19 for full testing of staff and residents to be undertaken and the results processed. Some of those test results took 5 days to process. That full testing has so far identified a further 3 cases, but management have told me that they will not be offered further testing, secondary testing, because it is being focused on priority cases. So will the Health Secretary confirm the delay of 3 weeks, or nearly 3 weeks, is acceptable, and that this delay will have put the safety of both residents and staff at further risk? And will she further confirm that Scottish Government guidance is clear that secondary testing should happen when there are confirmed cases, and that if NHS Grampian are not offering that testing, then they are in breach of that guidance?
Cabinet Secretary.
So let me start by saying to the member that if he cares to give me the details of that particular instance, I will investigate it directly myself this afternoon and tomorrow and get back to him. It is not acceptable to take 3 weeks before something like this happens. It is certainly not acceptable to take 5 days to process. I need to know which lab was processing that. Our NHS labs are working to a maximum of 24 hours. They do not always meet that at the moment. They need to get there by the end of this month, and they are actively engaged in doing that. 24 hours is the right time period for us to move into test, trace, isolate and support. In some instances, it does take longer than that, but 5 days is completely unacceptable. As is what the member has just said about secondary testing. I am not understanding why that was the view given either by NHS Grampian or reported by the manager, and I will want to look in great detail at what that was in actual fact and why the MD thought that that was the right thing to do, because it's not.
Ruth Maguire to be followed by Alexander Burnett.
Presiding Officer, residents and families must be assured that they'll receive the highest quality of care and that robust action will be taken where that's not the case. Can I ask the Cabinet Secretary how new powers proposed in the coronavirus bill will help bolster the work of the Care Inspectorate to ensure that that happens in practice? Cabinet Secretary.
So if I can just focus on one of the amendments that we have put forward, and as a way of, I hope, explaining why we think that this is necessary. And I need to preface that by saying that, these are powers that you would use in the last resort. But if we have a Care Inspectorate view that what they have inspected in a care home is of such poor quality that they intend to apply to the court to deregister that provider, what I don't believe we can do is wait for the court to go through its due process. I'm not criticising how long the court may take before we can step in order to ensure that the residents in that care home are safe, that infection prevention and cleanliness is of the standard that we need, that the numbers of staff to residents is of the standards that we need. So in those extreme circumstances, I think it is important that we are able to provide that additional safety net, regardless of the view of the provider in that instance, regardless of the court decision still to be made, but to move in straight away in order to do that, to protect the residents in that care home. Of course, as the member knows, that particular amendment does then require us to apply retrospectively to the court for the court's permission to do what we have done.
Alexander Burnett to be followed by Colin Smith.
Thank you, Presiding Officer. Given the tragedies occurring in care homes across the north east of Scotland, what amount of the £58 million pledged last week from the UK Government will go to the north east, and how will that be distributed?
Cabinet Secretary.
I'm not entirely sure what additional funding the member is talking about, but if he is referring to the additional funding, my apologies to him, I didn't quite hear clearly what he said, but if he is referring to the additional resource that the UK Government has committed to care home work, then the consequentials for that will go to care home work in Scotland.
Colin Smith to be followed by Kenneth Gibson. Colin Smith. I'm not sure Mr Smith can hear me. I think I'll call Kenneth Gibson while we wait for Colin Smith. Kenneth Gibson to be followed by Sarah Boyack. Kenneth Gibson.
Thank you, Presiding Officer. I should first declare that my mother lives in a care home. Cabinet Secretary, even before the pandemic, many care homes were struggling to survive. And in my constituency, care homes have closed in Arnlargs and Saltcoats in recent years. Financial support from local authorities for those placed by councils has struggled to keep up with the rising costs. Now that the additional costs of personal protective equipment, higher wages and higher staff to resident ratio has occurred, what steps will the Scottish Government take to ensure the continued viability of our care homes as the pandemic recedes?
Cabinet Secretary.
So as a member, I'm sure will know, many of our care homes do survive financially on the same basis as some of those who don't. that the standards that are required are the standards that are required, and where care homes fail to meet those standards, we've already discussed what needs to be done in that circumstance. The care homes are subject to a contract, the national contract, that they negotiate through Scottish Care with COSLA about the amount that will be paid for each resident that the local authority asks to be placed in a care home, currently done through the Health and Social Care Partnerships. I am sure, as part of the discussions that are continuing today between COSLA and Scottish Care around that question of statutory sick pay and making sure that care home workers are not put in that invidious position as a result of their employer's contract of employment, that there will be further discussion between those two parties on the national contract, and that I will not only be advised of what those discussions are, but from both parties what more they think needs to be done. And so we will be actively engaged as we go through this pandemic, not only in the additional resources that are required to get through the pandemic, which I have touched upon and which as government we have made available, but about the continuing sustainability of that sector, some of which will pick up some of the questions that Ms Bailey and others have already raised.
And before I call Sarah Boyack, I think Colin Smith. Colin Smith.
Thank you, Presiding Officer. Does the Cabinet Secretary accept that simply adding new categories to the list of those who can be tested in itself isn't enough? We know from our own communities there are many people already eligible that are simply not being tested. Carers and residents in homes with an outbreak, carers being told to travel miles to access a test. So will the Cabinet Secretary consider publishing the numbers tested by category of eligibility and by health board for each category on a regular basis so we can properly scrutinise delivery on the ground? And will she ensure that no one has to travel an excessive distance to access a test?
Cabinet Secretary.
So what I will commit to is to publish as best I can what data we have. And the reason I put that caveat on it is when the individual accesses the testing through the employer or the employee portal as part of the UK government's mobile testing or drive-through testing, where the tests are then processed at the Lighthouse Lab in Glasgow, we do not have all of that data. So if a care home worker or an NHS worker or an oil and gas worker goes through that route, that is not a route where we get the absolute data of every single category that has been tested. So there is a limit to what I can publish, which is the data that comes through our NHS testing. And we have consistently been clear that NHS and social care workers should be tested by the NHS and the process through the NHS labs. Those labs are quicker at turning around, notwithstanding what was raised earlier that I will look at, quicker at turning around those test results, and we have much more direct control over what those labs are doing. So the travel miles to access tests, where they are being accessed through NHS labs, then no one should have to travel miles. The travelling miles to access tests is where an individual goes through that employer or employee portal as part of the UK government, and they are therefore directed to one of the drive-through testing centres if a mobile testing unit is not nearby. And that's why we want health and social care workers to go through the NHS route. But I do agree with the member that there is no point in adding categories or adding capacity if we do not use that capacity. The capacity I can control is the capacity from our NHS labs, and work is underway right now to ensure that we can maximise that for all the areas and the groups that we have said are priorities for testing, including care home residents, care home workers, NHS staff, over 70s admitted to hospital and others.
Thank you. Sarah Boyack, to be followed by Richard Lyle.
Thank you, Presiding Officer. Can I say I would also like to hear the answer to Graham Simpson's question about the test results. I think many of us are concerned about that. It is very welcome that the Government are finally adopting the testing advice of experts such as Sir Harry Burns and Professor Hugh Pennington. The latter also suggested that the R number in care homes was likely to be high. Can the Cabinet Secretary give us an update of what the estimated R number in care homes currently is?
Cabinet Secretary.
No, I can't. As I'm sure the member knows, there are a range of experts in this area, in addition to the two that she mentioned. The advisory group that we have, chaired by Professor Andrew Morris, has been asked to look at what the R number may be in certain settings, including care homes. They are working on that. The difficulty that they have is that not every care home has an active case. Not every care home has had an active case since the outset of this. So looking at it as a sector as a whole, is difficult to do. Individual care homes have significant numbers of cases. Some only have one, many have none. So it is a difficult exercise for them to do with any confidence in the robustness of their modelling, but they have given us the assurance that they will continue to work and look and see what else they may pull in from experience elsewhere, because it is an answer that, or a range, the R number should be a range, that I would find very useful to know too. But at the moment, their response to us is, it is not possible for us to do that at this point with any confidence in the robustness of the answer we would give you, but we will continue to look at it.
Richard Lyle to be followed by Daniel Johnson.
Thank you, Presiding Officer. Cabinet Secretary, Highgate Care Home in my constituency was one of the first to declare the presence of COVID-19. Many of my constituents want testing to safeguard their loved ones. I have to declare that my brother is a resident of Highgate, and his daughter and grandchild, if they were here today, would surely thank you for your announcement today as I do. Can I therefore ask how often the staff and patients in care homes with COVID-19 will be tested? Will it be every week?
Cabinet Secretary.
So where there is an active case of COVID-19, then all the staff and all the residents in that care home should be tested. And the staff who are tested positive should be at home following the guidance that any of us should follow if we are tested positive, and the residents should be receiving the clinical care that they need through their primary care provider, that would be their GP practice, all of that now being overseen by the medical and nurse directors of the health boards, and the infection prevention and control measures in that care home actively scrutinised to ensure that any possibility of transmission from one resident to another is broken as far as that is possible to do. Of course, the member will know that for some residents in our care homes, indeed for many of them who suffer from dementia, that degree of isolation in your own room is particularly distressing. And so in those circumstances, what is needed is a degree of clinical guidance that supports the care home staff to manage that distress, to minimise the distressing situation while taking other mitigating measures to prevent infection transmission. For those care homes that do not have active case, the announcement that I have made is that care workers will be tested in those care homes, and that is a repeating process every 7 days. If any of the staff in the first round of testing is of course found to be negative, to be positive rather, then they would be asked to go home and follow that appropriate isolation and clinical guidance that we've spoken about, and then we would begin to test the residents in that care home, because we would need to be sure at that point that none of the residents in that care home had contracted the virus.
Daniel Johnson.
Thank you, Presiding Officer. According to the Financial Times, excess deaths due to COVID-19 stand at 55% in Scotland. That is exactly the same rate as in Italy and is amongst the worst in Europe. At the same time, in Scotland, use of ICU beds peaked at 208 on the 12th of April. That's just 18 more than the pre-COVID-19 capacity. It is hard to avoid the hypothesis that people have simply not been admitted to ICU in Scotland who would have been in other countries. And the situation in our care homes just underlines the suspicion this is even more true for those resident in those homes. So can I ask the Cabinet Secretary what steps she has taken to interrogate the data, to examine the policy and practice, and to ask the question whether people have been refused admission to ICU who would have been and should have been?
Cabinet Secretary.
Well, as the member said, he's talking about a hypothesis, and I would be very careful in suggesting that our clinicians at any level, in primary or in acute care, chose not to provide the clinical care that was appropriate for any patient for any reason at all. It is clear, and our Chief Medical Officer has been clear with primary care, giving them support, the BMA GP group, the Royal College of General Practitioners, all of them have been very clear with our GPs and our primary care practitioners that the right clinical care for an individual should be ensured and given regardless of that individual's location. And I have no reason and no evidence to suggest that that has not been the case, and that that applies too in the hospital setting when an individual is admitted. We have the clear guidance from the Royal College of Emergency Practitioners about the balance of decision-making that is undertaken in any circumstance, not just in this pandemic, but in any circumstance, between invasive, intrusive treatment that causes pain and may cause long-lasting harm. We've seen some of the emerging data about the potential long-lasting harm caused to individuals admitted to ICU and ventilated for any length of time through this pandemic. We've seen that emerging evidence. There is a balance always that clinicians have to strike between the care that could be delivered and the benefits of that care against the risk of damage and the failure of that care. And that is a constant balance of judgment that all our clinicians have to take, and is a very, very difficult place for them to be, and not one that I would wish to occupy myself. Certainly our group led by Professor Andrew Morris and NRS and our own senior statisticians are looking at the excess deaths numbers here and in the rest of the UK in order to interrogate those further so that we are sure what exactly lies behind them as best we can. And as they reach conclusions in all of that, then we will of course make sure that members as well as others are aware of those conclusions.
Thank you very much. And that concludes our statement this afternoon. We're going to move on shortly to the next item of business.